Thank you, Chair and Conference. Last year, this Conference voted strongly in favour of including support for water fluoridation in the Starting Well programme. So thank you for your decisive support. This year, Hull LDC is proposing a further motion on fluoridation, calling for the reallocation of the recurrent costs of fluoridation schemes away from local authorities to the NHS in areas where the dental health burden is high and inequality is wide. Why? Currently, local councils are suffering the most severe budget cuts in generations. Local authorities were eager to pick up the mantle of public health in 2013, but they now feel that they have been handed all of the responsibility, but without the appropriate resources. So, in this financial climate, what are the chances of cash-strapped councils finding additional funds for water fluoridation costs, even if local public opinion and local political arguments are won? We know water fluoridation is recognised internationally as a safe and effective oral health improvement programme. We know fluoridation reduces decay rates in children by a staggering 40%, increases the proportion of completely decay-free children by 15%, and reduces child general aesthetics by between 45% and 55%. Fluoridation reduces health inequality, and clinicians working in fluoridated and non-fluoridated areas notice, recognise the clear differences. Water fluoridation is acknowledged by Public Health England as the most effective and the most cost-effective prevention programme, delivering returns of £13 after 5 years and £23 after 10 years for every single pound invested. This return on investment benefits the NHS and not directly the local authority. So it is abundantly fair that the NHS covers these recurrent costs, which are modest, around £1 per person per year. So a few weeks ago, I was privileged to meet a group of health visitors in Hull, a community with amongst the worst child dental health in England. They told me in no uncertain terms that their communities need help. And why wasn't more progress being made on fluoridation? I agree, it's time to stop talking and start acting, to begin looking at can do rather than can't do. Like last year, this motion provides us with the opportunity to send a strong message. The reallocation of recurrent fluoridation costs away from local authorities to the NHS would be a start, removing a significant barrier to improving oral health. Conference, voting in favour of this motion can make a difference. Conference and the LDCs can take a resounding vote forwards, together with the BDA, the British Society of Paediatric Dentistry, the Royal College of Paediatrics and Child Health, the Royal College of Surgeons and others. We can use this vote to lobby even harder for this really important change. Thank you for your support.
Thank you, Simon. Next to speak for the motion is Sam Watson.
Thank you, Chair. Conference, I stood here with Simon last year to support his push with water fluoridation. I came prepared with a few elements, and Stephen Fail has systematically taken them all from me and delivered them in a very nice presentation, so I shan't labour over those. But in a recent stock take from 2018 of local authority commissioned oral health programmes, we've seen that 11 local authorities are considering water fluoridation. That's a big shift for what is a brave new world for local authorities in being responsible for public health, but particularly for oral health. It's a big, big change from the PCT remit of old. And I think they really need that support, not just financially, but the continued support from organisations and from people like us to say that we are behind you, you're not alone here. And yes, it is complex and it's a brave decision, but there are people behind you who will help you. And we know the evidence speaks for itself. That same document that explores the local authority stocktake compares fluoridated Hartlepool and how the 5-year-olds are 50% less likely to have tooth decay than non-fluoridated Hull. I don't want to labour the evidence, it's there and we all know it, but it's that support that's really important. Please, Conference, vote for the motion.
Thank you. We have no more speakers for that motion, so we shall go to a vote. It is a UK vote. So all those in favour? Nice and high. And all those against? Any abstentions? Majority? Unanimous?
Afternoon, Conference. We all know that local authorities are under increasing financial pressure, and this will continue to affect the scope of public health initiatives that can be provided locally, including children's oral health programmes. So if good resources have been developed to tackle tooth decay in children, it's important that they are shared so they can be used or replicated in other regions. This will keep costs down for local authorities and ensure consistency of messaging for parents and children. So we're grateful that in response to the high level of children's tooth decay in our borough, the fantastic team at Westminster City Council have driven an initiative to educate children and parents about sugar and dental decay and encourage attendance at dental practices. This programme includes an engaging video for young children, which everyone can access online, and this is being promoted both in dental practices and schools. There's a quiz at the end of the video, which is used to reinforce messages and remind viewers that NHS dental care is free for children. There's activity sheets for teachers in schools, which tie into the national curriculum, and other materials include leaflets for parents and a range of stationery for schools and dental practices with links to the programme webpage. Throughout the creation of these resources, the public health team worked with the Westminster LDC to gain feedback from dentists and make changes to make sure this programme will be well received by professionals in the area. And a reminder from what we heard earlier, 1 in 4 children in England have dental decay when they start school, and each child with tooth decay has on average 3 to 4 teeth affected. And Prof. Vale talked about the national initiatives being set up. We cannot just wait for these initiatives to filter down to the local level. And it's for this reason we commend the initiative set up by Westminster City Council to address tooth decay in children and promote attendance in local dental practices. And we urge any local authority which is concerned about the oral health of its children to contact the team to see if the successful introduction of this programme can be replicated in their area. And finally, we encourage all LDCs here to work with the local authorities to make use of these materials and see if further collaboration can be of use to LDCs and dentists, schools and teachers, and parents and children. Thank you.
Thank you, Sagar. This motion also includes motion 9A. And are there any other speakers for the motion? So we shall go to a vote. We'll take motion 9 first. This is a UK vote. So all those in favour? All those against? Any abstentions? That looks unanimous to me. Yeah. Motion 9A. LDC Conference welcome the initiatives of Dental Check by One and Starting Well. All those in favour? Sorry, this is England only. All those in favour? All those against? Any abstentions? That looks unanimous. Yeah.
Thank you, Chair, for enabling me to speak. Just so that you all know which hat I'm wearing speaking to this motion, I'm speaking with my hat on as the Senior National Advisor to the Care Quality Commission. And I wanted to share with you that CQC is aware, very much aware, of the challenge to provide good oral health care for residents in care homes, residential homes and nursing homes. We're also aware of the importance of good oral health in relation to general health and well-being. CQC, as you know, does inspect care home and residential care. During the inspections of that, we do expect to see NICE guidance being followed. And I'm sure you're aware of the guidance that NICE has produced about looking after the oral health of people in these residential settings. So we expect to see NICE guidance being followed. The CQC is looking at what more we can do to influence improvement in this important area. And in my role as National Advisor, I will keep the profession informed as we move this agenda on. Thank you.
Hello, Conference. I am Pratik Patel, Co-Chair of Brenton Harrow Local Dental Committee. I would like to speak in favour of this motion from Wakefield LDC and for the two motions from Brenton Harrow LDC, which are included underneath it. As has been eloquently explained, older adult oral health care is a serious issue that needs to be addressed. This is why we support an integrated whole system approach to ensuring that the most vulnerable in our society have the care that they require. My LDC considers that it is important for a single body with parliamentary support to have oversight of any plans for addressing this issue, hence our motion 10B, which calls for the all-party parliamentary group to hold an inquiry on this issue and to work with stakeholders to implement effective recommendations and then to hold an annual review on progress. We see this is complementary to Wakefield motion. We also think it is important for regulators to play their part in facilitating care, which is why we have proposed motion 10A that the CQC works with social care providers to facilitate partnership working. This will make it more clear to local bodies where gaps in services exist, where extra funding is required, and where regulatory and contractual developments are needed. I urge Conference to support all the motions being proposed on this important issue.
I'd like to call Jason Wong to speak. I'm not sure whether it's for or against, Jason.
Sorry, it's for the motion.
For the motion, thank you.
Thank you, Chair. I'd like to speak for the motion for this and the other sub-motions that there are. I think they're all sort of congruent to the same theme. In terms of the 10C motion that Lincolnshire LDC has proposed, if you take the FGDP dementia-friendly guidance, you will see that the requirements for making dental practices dementia-friendly are the issues surrounding surgery designed for patients with dementia are very similar to those for all patients. The environment has to be understandable, comfortable, clear signage, well lit. They're not difficult things, in my view, for dental practices to try and adapt to a pace. And I would like you to support this and the other motions that are there as well.
Thank you, Jason. Richard Grant, speaking for the motion.
Good afternoon, Conference. I'm Richard Grant from Northumberland and I'm an observer this time round. I used to do domiciliaries years ago under the old item of service, and it seems to me that all of these issues in connection with domiciliary visits, care homes, residential homes, could be quite simply resolved by the department recognising that there are additional expenses involved in making such visits and taking equipment, and including, in theory, resuscitation equipment and all the rest of it, and recognising the fact that there is an additional expense involved and paying us accordingly. It's as simple as that. Make it financially worth our while.
Thank you very much.
Thank you for the opportunity to speak, Mr Chairman. Conference. I'm going to go back to motion 10C about the dementia-friendly practice. I'm fully in agreement with that motion because the most demented people I see are the dentists and the staff running around trying to meet impossible targets and service the needs of their patients. It's clear to me that the UDA contract is getting further away from doing that. Aggressive policing by the BSA makes it nearly impossible to treat patients' needs as we find them coming through the door. Contract reform doesn't seem to do that either. And what we really need is a fresh look at this. We have loads and loads of the population with high needs that are not welcome in either system. So I don't think we can tweak the UDA system. I think the way contract reform is going, we will be decay-free in our population before that has any effect. And that is not because of that reform. It will be because we're all so old that decay has become a thing of the past. So I support a full new look at the way we deliver NHS dentistry in this country. Thank you.
Thank you, Mick. I don't have any more speakers looking to address these motions, so we should go to a vote. So we'll start by voting on motion 10. That can be put up for us. So I'd like to call for all those in favour. All those against. That motion is unanimous. Thank you, Conference. That's a good start. Is that a pint, Henrik? Motion 10A from Brenton Harrow. All those in favour? All those against? That's carried unanimously, I think. Motion 10B, Brenton Harrow. All those for? All those against? Abstentions? That looks as though that's been carried as well. Thank you, Conference. Motion 10C, Lincolnshire LDC. All those for the motion? And all those against? Abstentions? That looks as though that's unanimous as well. Thank you very much, Conference.
So after being first announced in 2016, the soft drinks industry levy, or the sugar tax, was finally introduced this year. And many companies have reduced the sugar in their products to minimise these costs. Meanwhile, the revenue raised from products above the threshold is to be invested into programmes preventing health issues caused by sugar. But although obesity and diabetes often take the headlines, we all know the impact that sugar has on children's oral health. Another statistic, in England, in 2016 to 17, over 34,000 children under 10 were admitted to hospital because of dental decay. We all know the risks associated with GAs and should be doing all we can to avoid putting children through this. The national dental budget, as it stands, will not be sufficient to meet the needs facing the population. And meanwhile, the local authorities that now have the responsibility for public health and children's oral health but do not have the funding to match. These two issues are not going to be resolved in the near future. So if we want to reduce dental decay in children, funding from us elsewhere must be found. which is why we are calling for a proportion of the funds from the levy on sugary drinks be used to address children's oral health. Regional differences require that this proportion and how it is used to educate children and parents on the oral health risks of a high-sugar diet must be determined at the local level. And this is why it's absolutely vital that LDCs engage with their local stakeholder groups, including local authorities, to ensure that the needs of their population is understood and the needs met. We're confident that this proposal will find support amongst parliamentarians of all parties, as this very proposal was made by the former chair of the all-party parliamentary group on childhood obesity in a recent debate on oral health. Tooth decay is a public health issue that requires interceptions and strategies at the national level. But the variation in the extent of this disease requires local engagement, and this needs to be led by the local dental committees. Thank you.
Thank you very much. Have we anybody speaking to this motion? Looks as though we'll go for a vote. It's a UK vote, so everybody can vote on this. All those in favour? No, it's better. All those against? Abstentions? Carried. Thank you.
Good afternoon, Conference. The All-Party Parliamentary Group on Dentistry and Oral Health can provide a high level of accountability and profile to this issue. In 2014, the British Society of Oral Medicine and Cancer Research UK issued a statement on mouth cancer diagnosis and prevention, which included recommendations for reducing the use of tobacco and areca nut use. The statement and recommendations had wide-ranging support from the Chief Dental Officers of England, Wales, Scotland and Northern Ireland, the Royal College Dental Faculties of England, Glasgow and Edinburgh, the British Dental Association, the British Dental Health Foundation, and the British Societies and Associations representing oral and maxillofacial specialities. NICE identified smokeless tobacco use as a cause of concern among South Asian communities, resulting in the publication of guidance in 2012 for directors of public health. Misperceptions about the risk of shisha remain widespread. While use is estimated to be low at 1% to those over 24 years of age, 2% of 18 to 24-year-olds are using it regularly once to twice a month. Prevalence increases among the Asian communities and the British Asian community, with 7% using shisha. While the issue may not be a widespread national risk, it is clear that certain groups are high users and therefore at an increased risk. In South East London, a study showed that 39.6% of secondary school children had tried shisha, and in Brent, 24% had tried it. Amongst university students, this figure is 37.9% in Birmingham, with 8% using it regularly, while in London, 51.7% had used it, with 11% regular users. Shisha tobacco is often imported illegally and therefore of an unknown origin and quality. The number of shisha bars has increased from 179 to 556 between 2007 and 2012. That's a 210% increase. There are herbal shisha too, but research suggests that these are just as harmful, with the smoke produced containing large numbers of carcinogenic compounds such as polycyclic aromatic hydrocarbons. A WHO report in 2014 indicates that smoking shisha for an hour is equivalent to the inhalation of smoke of 100 cigarettes. Similar misconceptions exist around the use of betel nut products, which are often regarded as carcinogenic, but are publicized as legal highs. A study in London showed that the vast majority of palm and betel nut users were unaware of the health implications. The Bangladeshi community in London has higher rates of oral cancer because of the large use of tobacco, smokeless tobacco, and betel nut use. The same report also found that 38% of those involved in the study were not regular dental attenders. This presents a good opportunity for increased engagement. It's time for local authorities to identify communities at risk in their joint strategic needs assessment to work with the profession in improving oral health and oral awareness of this issue. This motion will help increase accountability and make sure that guidance, once published, is simply not forgotten, but is implemented sensibly, and its effectiveness measured. I urge conference to support this motion. Thank you.
Thank you. Have we anybody to speak to the motion? No. Shall we go to a vote? So it's sorry. Oh, sorry, we did have somebody. I was wondering where he went. Sorry. Chair-elect is going to speak to the motion. He didn't give me a slip.
Davinder Pal, thank you. I think you're a first-time speaker as well. Oh, there you are, sir. You're well done. Thank you. I commend the spirit of this motion. The problem I have with it is it's asking for yet more targets that will be used potentially to beat us with. And clearly there's never going to be any additional funding. So this will be another tick box for those practitioners who work in areas where their patients use betel nut and smokeless tobacco. So I commend the spirit of this motion, but we just have to be very careful what we ask for. Last week I had a letter from the NHS BSA. I was told I was an outlier for provision of inlays. It said that the target nationally is 5.7%. At my two sites, my figures are 0% at one site and 0.2% at the other. So I'm an outlier. And basically they've told me they'll keep an eye on me, and then if this trend continues, they will monitor me next year and ask for an explanation. It's crazy.
Thank you, Vijay. So we have Peter Tatton speaking against the motion.
Conference, surely...
Conference,
surely the LDC should be engaging with the local authorities and not asking conference to call on all local authorities to engage with their LDCs. I don't think we can support this motion because the wording is not correct.
Thank you. Have we any other speakers to the motion? Shall we go to a vote? So it's a UK vote. So all those in favour of motion 12? Hands up high. All those against? Abstentions? Let's go to a count. Okay, BDA staff, wiki. Can the staff give me all a thumbs up when they're happy with the count? So, all those in favour of motion 12, can you raise your cards? Okay. All those against? Hold them up high. Okay. And abstentions? Abstentions might have it. So the results of motion 12, or the votes for the motion were 36, The votes against, 41. 27 abstentions. Thank you very much.
Good morning, Conference. I'm Narish Gohill, not Ian Duthie. We know that dentistry is not at the top of the priority list for the NHS or for the Department of Health and Social Care. We also know that primary care dentistry is not very well integrated into the rest of the health system. We also know that these states of affairs cannot continue. Mental health is a key policy concern for the government, Department of Health and NHS at the moment. As clinicians, dentists can make a valuable contribution of helping minimize the risk of conditions such as bulimia and signpost patients to appropriate avenues of care. The eating disorder charity BEAT estimates that 1.25 million people have an eating disorder in the UK, 11% of them being male, while anorexia and bulimia care estimated at 1.6 million. Dentists are often concerned that they are not engaged with and forgotten about. Let's make dentists' contribution to this issue clear. Local CEP and the community education provider networks are the perfect opportunity for interdisciplinary training, and this is an important issue for the whole primary care workforce to address together. Let's work together with local stakeholders to create local networks and demonstrate our value. The funding is there, the issue is there. Conference, please support this motion and show the public that the will is there too. Thank you.
Thank you very much. We've got Paul McCrory from Bury talking against the motion.
Yes, I support the sentiment associated with this motion very, very strongly. And I think that where possible, dentists should do their very best to try and help with the management of other medical conditions which are outside our normal field of practice. But I think that there are real dangers in us going down the route of find and treat, which effectively this is, without having proper guidance on what we can do and what we can't do. If we're referring, then it may well be appropriate for us to do blood sugar or blood pressure testing, and we can justify that, and we will have indemnity cover for it, and we will not be breaching regulations or potentially be reported to a regulator. In the event that we're just doing it as a screening measure, then I think that there are potential risks. And what I would suggest is that suggestions like this are considered very seriously, but the BDA, in conjunction with the indemnity providers, should sit down and they should take a proper look at things, and they should provide guidance to practitioners before we go down this route. I support the sentiment and the idea of going down the route as far as we can, but I think we need to be very careful about where we go, and there should be proper guidance to practitioners to ensure that they're not leaving themselves open. Thank you.
Thank you, Paul. Have we any other speakers? So we'll go to a vote. Again, this is a UK vote, so you hold up your green cards. All those in favour? All those against? Any abstentions? Majority carried.
Yeah, morning, Conference. Just to reassure those of you who know me, I've not become a vegan, teetotal, eco-warrior, but a couple of things happened recently that made me think about this. One was Blue Planet 2, which I think touched a lot of people's thoughts and has changed policy on a number of areas. And the other was appointing a graduate from Valencia. So During his induction, we got talking about cross-infection control, and in Valencia, they buy their own equipment as students, including handpieces. So how do you track your handpieces for sterilisation? So you can't sterilise handpieces, that's stupid, they're far too expensive. They just wipe them down. Okay, what about other disposable things, 3-in-1 tips? Well, metal, obviously. Why would you use anything other than metal? And so, well, okay, what else do you use? We've got these reciproc system. We throw them away after every use. Well, that's stupid. They're far too expensive to throw away. In Valencia, they put them through the autoclave because obviously the prions in Spain aren't as dangerous as the prions in England. And it just got me thinking that we all took on board HTML 105 in 2009, and we accepted that bacteria would ingress that wrapped pouch in 21 days and suddenly be dangerous and would need re-sterilising. And I know it's changed so that that's a little bit more pragmatic, but what's the scientific base behind all the guidance that we follow, given that in Spain they have a completely different view? So when you actually look at the plastic waste side of this, if there's 80 million UDAs delivered in England, 39 million courses of treatment, and you use 2 3-in-1 tips for each course of treatment, and you put those into containers, a standard 40-foot container, and you line them up on Wembley pitch, that would fill Wembley pitch in a year. That's just 3-in-1 tips. Now, I know they're incinerated, so they're not plastic waste that's going to end up in a river. But why are we doing it? We're just doing it because somebody said we should and there's no scientific base. So I'm just calling for a re-evaluation of what we're doing to put a bit of logic to it.
Thank you, Ian. Have we any speakers? Thank you, Peter. Peter Tatton, Hertfordshire. He is speaking for the motion.
Conference, I'll just make this very quick. We were promised a review of HTM 0105 by the previous CDO. It never happened. We've been lumbered with this total non-evidence-based regulation, which has wasted millions of our pounds. If this motion is passed, I hope it will stimulate the GDPC to act on this. Thank you.
Thank you, Peter. Any other speakers to the motion? Shall we go to a vote? This is an England vote because it's specifically about HTML 105. Have you got HTML 105 in Northern Ireland as well? Okay, let's make it UK then. Because if it's in Northern Ireland, it must be in Wales and Scotland. So, okay, this is a UK vote. All those in favour? Hey. All those against? Any abstentions? Unanimous. Thank you for that correction down there.